Okay, brief little lecture here about pediatric ears and eyes. I like to point out differences in between your adult patients and your pediatric patients since you've already had your med-surg, so we can just kind of draw out what maybe you haven't talked about. Pediatric patients tend to have more ear problems than adults do because their eustachian tube that connects the nasopharynx to the middle ear is shorter, wider, and more horizontal than it is in adults. So during sucking, yawning, and other movements, the tube opens, allowing free passage of air between the nasopharynx and the middle ear, and this predisposes children to otitis media or middle ear infections. Their external ear canal is small, and their middle and inner ear are large. So tympanic membrane is closer to the surface in children than it is adults, so it can be more easily injured. Hearing, we talked about babies can hear starting in utero around 20 weeks gestation, so children should be able to hear. The auditory nerve function is mature by 5 months of age. We know that they do the routine hearing screen in the hospitals. Remember your ear assessment for children less than 3 years of age, you pull the pinna down and back, and for greater than 3 years of age, you pull it up and back. Hearing impairments we've talked about can affect speech, motor development, growth and development. It can cause delays in their growth and development. And we talked about, other than hearing screening, what are some ways that we can tell that a child can't hear appropriately, and they're listed here. If they can't hear appropriately, we want to promote their independence, refer their child and family to appropriate resources, identify safety hazards, and promote the use of hearing aids. So acute otitis media versus otitis media with effusion. So acute otitis media, or AOM, is an infection of the structures of the middle ear. And otitis media with effusion, or OME, is collection of fluid in the middle ear, but there is no infection present. Remember, the eustachian tube is more horizontal, or shorter and more horizontal than it is in adults, so kids are at increased risk for this. This is very common the first 24 months of age and at the age of 5 and 6. So kids start going to school around 5 or 6, so they're exposed to more infections at that time. It is very uncommon after the age of 7. Breastfeeding can decrease the risk of this because of the IgA present in breast milk. If repeated infections are noted, then it could lead to hearing loss and speech delays in the kids. Acute otitis media findings. So this is your one with infection. The child may be rubbing or pulling on their ear, crying, lethargic. You may see a bulging yellow or red tympanic membrane, no or decreased tympanic movement, swollen lymph nodes, fever, and drainage from the ear. Remember your normal tympanic membrane finding, it should be pearly pink or gray. And with this infection, you have the bulging yellow or red. Otitis media with effusion, so this is without the infection. The child may feel a fullness feeling in their ear. There may be an orange discoloration to the tympanic membrane with decreased movement. So normal is pearly pink or gray. Infection would be yellow or red, and fluid with no infection would be orange. This could lead to hearing loss if it's not resolved, and balance disturbances. Treatment, obviously pain control. Remember appropriate pain scales that you use for children. Diversional activities, Tylenol, Advil, preferably PO. Eardrops. Positioning for the baby, keep the child upright since that eustachian tube's very horizontal. Keeping them upright will prevent that, hopefully that fluid to go into the middle ear. We like to wait 72 hours for spontaneous resolution before we administer antibiotics. Overuse of antibiotics could lead to resistance, so we want to see if it'll clear on its own. If we do give, we want to give antibiotics orally in high doses for 10 to 14 days, and it's important that you tell parents to make sure that they finish that. Tubes. So this is an outpatient procedure, usually only lasts about 15 minutes. They go in, they put a small incision in the tympanic membrane and place tiny tubes into the eardrum to equalize pressure and minimize effusion or fluid collection. They can experience mild pain. Tubes come out spontaneously in 6 to 12 months. You want to tell the parents to limit the child's activities for a few days, notify the provider when the tubes come out. Avoid getting water into the ears. Feed the child in the upright position. For drainage, clean external ear with sterile cotton swabs. Avoid putting anything down in the ear. Avoid secondhand smoke. Avoid people that have known infections. Keep immunizations up to date to decrease the child's risk for infections. Report problems to the provider, such as tugging at the ear. Eyes, just real brief here, difference in between your adult and your pediatric patients. Visual acuity is different. Lens is more spherical, so cannot accommodate near and far. The optic nerve not completely myelinated, so you can't distinguish color till 6 to 12 months of age. The rectus muscles are underdeveloped, so binocular vision is decreased. The cornea occupies a larger portion of the eyes, so there's increased risk for injury to the cornea. Sclera of the eyeball is thin and translucent. That's why you get that bluish color until 6 to 12 months of age. And the lacrimal system drains tears to the nasal cavity, so there's no tears when they cry, when they're infants. Their eyes should be aligned and movement should be coordinated by 3 months of age. I know we've mentioned the different screening tools for vision. Here's pictures of some of those so you all are familiar with the Snellen chart. They also had the tumbling E or the picture chart where there's just different pictures and the child says what picture is on them. And then how they test colored vision or colored blindness is, you all have seen these tests before.